Thank you so much, Drs. Galvani and Jackson, for the invitation to present to you all today. And I'm really pleased to be here. All the talks have been wonderful so far. So this is my disclosure slide. And I actually have another disclosure. So I personally don't do poems, but I do lots of myotomies. Why I don't do poems? Because my partner is Jeffrey Marks. So at my institution, I don't need to do poems. So I have to thank Jeff in advance for a lot of the that's in here on my talk about poems. But because I do a lot of myotomies, I also will interject with a little bit of an opinion from my own experience. So over the next few minutes, we'll talk about intraoperative, perioperative, and postoperative complications. So as you all know, myotomy's been around for a long time, right? It was a big progression from the whalebone down the mouth. So really great way to help with dysphagia. And for me, it's actually one of my favorite operations that I do because I come in, I split the muscle, patient can't eat, day after they can eat, they're so happy, so it's a make my patient happy operation. So then Jeff starts doing these poems, and now in a short period of time, thousands and thousands of these cases have been done worldwide, and amazingly, also in less than a decade, there's over 650 citations in PubMed. So this procedure has ramped up quickly. And I actually remember when Jeff Marks and Jeff Ponsky did their first poem at UH, and I was like 39 and a half weeks pregnant, but I wasn't delivering yet, so I was like, I'll go watch them do this poem. And it took them a bit, but then they got through the learning curve quickly, and it's because they spent time with Dr. Inouye, who had invented the procedure and first described it. And just to go through briefly, I think it's really important to know how this is done so that you can anticipate what some of the different complications might be and how you can avoid them. So we get into the submucosa for those of you who might not have seen one, and then you always have a cover on the end of your scope, and you kind of develop the plane in that submucosal plane, take the triangle knife, and Jeff calls this the cotton candy that he's injected with the blue dye, and you create this beautiful submucosal tunnel all the way down the esophagus, down onto the gastric wall. And so you're leaving, right? Your esophagus doesn't have a serosa. You're leaving a very, very thin esophagus. So if you think about exactly how this is done, of course, you can anticipate a lot of the complications you might see. And at the completion of it, you start to see the crossing fibers on the stomach. You'll pull your scope out of the tunnel, look retroflex to make sure you see the distal end of your myotomy going onto your stomach. And then once that's done, you clip the mucosotomy closed. So, myotomy. The reasons I like a Heller myotomy, it's relatively simple procedure to do if you're well trained. It's extremely effective. Patient notices a difference right the next day. Perioperative complications are extremely low. We've been doing it for over 100 years, so if we're still doing it, it must be pretty good. And we can also concurrently fix reflux by doing an anti-reflux procedure. And if there's a concurrent hiatal hernia, we can address that too. Now, the downside of it is an operation, and so patients like the idea nowadays of having an operation through their mouth versus having to have incisions on their belly, and of course, we are disrupting a lot of the sling fibers in the area of the hiatus. Poem has no abdominal entry, no scars, less pain. We preserve the anti-reflex mechanism, but the downside is that, you have to be an advanced endoscopist to do this. Nobody can just pick this up. If you don't do basic endoscopy, you're definitely not going to do poems. Obviously, there's potential for complications, and that's what we're here to spend the rest of this talk on. There's not a lot of long-term data on this, and of course, the Achilles heel of this operation, you'd say, where's the rub? It's reflux disease, so we'll talk a little bit about that as well. So, if you go online, you do a Google search, and you say, what are the most common complications of poem? You can find all kinds of references. The things that come up: pneumothorax, pneumoperitoneum, esophagitis, reflux, and then a smattering of other things. And, sometimes you might see the images that you see on the right side of the screen there, and you're like, wow, that looks really bad. But in talking to Jeff, I'll highlight some of the things that he shared with me. Then I found this 2-year long-term safety and efficacy. That one was more 1 year. And in here, again, similar things, subacute emphysema, pneumothorax, mucosal perforations, mediastinal emphysema, but none of them were described as major adverse events, but the incidence of reflux is real. Most importantly, no mortalities. So let's go through some of these different complications one by one. First, there's anesthesia, right? We want to use general anesthesia for these cases, because you don't want these patients to operate because they might have an esophagus full of food, so you definitely want to keep them. We put them on a clear liquid diet for 1 or 2 days, depending on the severity of their disease. Jeff said he sees a lot of arrhythmias, and a lot of these patients he thinks are under beta blocked, and they'll develop SVT. So something you want to make sure you have good cardiac monitoring. And then, of course, if they've only been on the clear liquids and not drinking enough, they might come in dehydrated. So all things to talk to your anesthesia about. Usually use a rapid sequence intubation so that you can avoid some of these problems. So now let's get into the procedure itself. Bleeding is the first thing you're going to think about, right? You get into that submucosal plane, you're in a very tight tunnel. You literally have tunnel vision when you're looking through the end of the endoscope. So if you get any bleeding in there, it's going to make things fairly difficult. The good news is that if you get into the right plane and you do this right, bleeding is fairly rare. But if it happens, you can control it pretty easily, either with some thermal energy, by grabbing whatever you see bleeding with a coagulation grasper. You really kind of want to avoid banding because it's really hard to get a bander into that submucosal plane. And also injecting, when you're in that tunnel, all you got is that longitudinal muscle out there, and you really don't want to be injecting into that area. So injection should be avoided. Now, pneumothorax, capnothorax, that's probably one of the most common things that you see. We even see that with mediastinal dissections in our foregut surgery. But most of the time, that resolves on its own. So it really doesn't become a major issue for the patient. Interestingly, as we're doing this, some of the patients, we've seen with Jeff, he notes that some patients will get a pneumoperitoneum, just like you can get with a colonoscopy, for example, and so they develop this massive pneumoperitoneum. They can develop like an abdominal compartment syndrome, like you might see with a TEP or something. What do you do with that? You stick an angiocath in the right upper quadrant, okay? You can decompress it, and fairly easy to do or to fix. Perforation is extremely rare and almost never happens, and then that mucosectomy can just start to tear apart. Especially in some of your more fragile patients, the more end-stage achalasia. And so this is where you might even pull out other endoscopic tools like the overstitch or clips. Once your patient gets to the recovery room, guess what? The patient can still bleed, okay? And our experience at UH, when Jeff looked at his data, 4 out of 350 patients had bleeding postoperatively. Some bled into the tunnel, some bled into the lumen, and he noticed that all 4 of those patients were on antiplatelet therapy more aggressively than most of our other patients for whatever comorbidities they might have. So, if you have a patient on antiplatelet therapy, really be careful about that. If they're bleeding in the tunnel, then you may not see a lot of symptoms other than just dysphagia. And if you're worried about that, get a CAT scan to look at that if you want to image it. And sometimes you just might treat it symptomatically. We do get an esophagram in every patient the day after the procedure. If it's intraluminal and they're like vomiting blood, it's pretty, it's probably easiest just to take them back to the OR, rescope them, find the bleeding, clip it, cauterize it, whatever you need to do to get that fixed. The other thing that we've noticed is leaking into the tunnel. And most of these patients have been actually asymptomatic, and it's been an incidental thing that we've seen on the upper GI the day after the procedure. And so when we see that, Jeff said none of the patients he's seen with it have been symptomatic. But it always makes your heart skip a beat, because you're always like, well, what if that tunnel, what's on the other side, could easily go someplace else and make the patient really sick, put them on antibiotics. He'll do serial esophagograms for a day or 2, and then in extreme situations, if doesn't look like it's improving, you take them back, scope them, and actually just put a couple extra clips on that tunnel closure. And this hasn't happened in our experience, but some people have reported just total mucosal ischemia, and that's just a really, really rough situation. You're going to go into supportive care and do what you got to do for the patient, but don't ever stent them. The other thing that patients might have early in the postoperative period is chest pain or shortness of breath, and when you get a chest x-ray, we'll notice a lot of atelectasis. And so incentive spirometry and aggressive respiratory therapy is very helpful. So now let's get a little further out. So gastroesophageal reflux disease. Our standard protocol is to keep all of them on PPIs for 6 months. We try to get them to come in for a Bravo. The interesting thing is that, if a patient has symptoms, they're only going to have pathologic acid reflux with the Bravo 50% of the time. And if they have no symptoms, you're going to see a positive Bravo 50% of the time. So really the only way to know if they really have reflux is to actually measure it and to do a Bravo. We have maybe 30 to 50% follow-up. A lot of patients, if they feel good, they just don't want to come back. And of course, we have a wide referral base, so they don't want to drive all the way back if they don't have to. And then I think Barrett's is something we should also think about. And then, of course, persistent dysphagia or non-resolution of the achalasia, just like we can see with a standard surgical myotomy. And really, strictures are not a thing after POEM, so it's not something to worry about. At the bottom of the screen here, we had a patient just recently who had persistent dysphagia, and this was their manometry. And so you can see that over here that in the proximal esophagus, they maintain some, some contractility. Looks like this is where the myotomy was, and it's completely defunctionalized. But then there is a little bit of persistent pressure in the LES, and you're not appreciating a lot of relaxation. So Jeff's actually going to do a repeat myotomy, although the LES pressure was 10, 12, but the IRP also was right around that area. It wasn't relaxing at all. So something that you can see. So let's talk a little bit about Barrett's after these surgical myotomies. One of the first reports of Barrett's and achalasia was back in 1994. And in this particular study, they noted over 6% risk of Barrett's. And these patients presented with Barrett's anywhere from 6 to 23 years postoperatively. So of course, in the POEM population, we don't have this follow-up, but knowing that reflux is a thing, and you're not doing any anti-reflux procedure with it, then we gotta worry about that. So, if we look at post-POEM, this was just happened to be a case report that I found that this patient had an esophageal nodule, noted 4 years later when they presented with more dysphagia and ended up being some Barrett's. So it's out there. Now, Dr. Inouye did a consensus statement. He brought many centers from around the world together to really look at this question of GERD after POEM. And I just want you to pay attention to the right column here. And basically, for every question, there's really not a lot of evidence. Even though there's like 600 or 700 articles in the literature, hey, we still are lacking in a lot of evidence. So I think there's still a lot we don't know. And so we need to continue to study our patients, gather data so that we know what we're doing for our patients. In that review, interestingly, anecdotally, there was a group from Japan that said, well, if you do 2 scopes and you put 1 scope in the lumen and 1 scope in the tunnel, and you limit how far you go onto the stomach, you might decrease the amount of reflux you have. And they said, make sure you go under 4 centimeters. And interestingly, Jeff only tries to go 2 centimeters. So clearly there's some ongoing variations in technique. This is our complication rate when we reviewed our data. Out of 70 patients, we only had 1 pneumothorax, some persistent dysphagia, and 4 patients did have redo POEMs out of those 70. And 1 ended up with a Mallory-Weiss tear, only 1% risk of bleeding, but GERD in 23 of those patients, so a little over a third. And if we look at complications of myotomy, very similar, right? GERD, dysphagia, bleeding, injury to surrounding organs. So let's look at a little bit of the literature out there comparing POEM to myotomy. And in this study, what was the benefit of POEM? Less narcotics. What was the downside of, or the other upside of POEM? They got discharged quicker. So in this study, they said, yay, go POEM. And then if we look at this other study, okay, And this study is from 2016. They said, again, improved quality of life. People are happy on their Eckhart scores, and type 3, and this is where we started thinking more about type 3 achalasia benefiting more from the poem. And they felt that there was a similar amount of relief with postoperative PPIs. But remember, I told you that symptoms have nothing to do with how bad the GERD is in these patients. So that's something to really keep in mind. And if we look at quality of life, again, similar incidence of GERD in this particular study. But then when you start to get into more studies, Dr. Ujicki did this beautiful paper looking at the short-term outcomes with myotomy versus POEM, noted that pain was actually a lot less with the POEM, and the Eckhart scores were significantly improved, but the POEM group recovered a little quicker. So yay, go POEM again. And then if we looked at symptomatic and physiologic outcomes further out, okay, again, now we're starting to see that there's actually a little bit more reflux out there. And then this was a case-controlled case-match study. And if you look here, esophagitis was seen in 53% of the POEM patients versus 31% of the Heller patients. So this is kind of the big study that we did. When I was at Vanderbilt, I was a fellow. We looked at a randomized trial of Heller alone versus Heller plus DOR, and we definitely noted that there was a significant benefit to doing a concurrent anti-reflux procedure. I started this during my fellowship, and kind of all the long-term outcomes got finished after. So, if we start to look at some further studies, we start to see that really reflux is a thing in these patients. And so we really want to think about that. Barrett's, okay? GERD in this study, 11% in the Hellers, 22% in the POEMs. pH studies, now we're getting some objective data, not just symptoms. 11% in the myotomy, surgical myotomy, 47% in POEM. So now we're starting to see a significant increased amount of reflux. So I think reflux is really going to be, as we know, is the Achilles heel of the POEM. And I referenced that article from '94 that showed that Barrett's can show up anywhere from 6 to 25 years later. So it's something we all need to pay attention to. And, I think everyone's obviously very vigilant about it, but, definitely the patients wanting to have less pain, less intervention is definitely a thing as well. So right now, long-term durability may be similar to Heller, but reflux is something we should definitely pay attention to. Thank you so much for your attention.